This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1092, recorded on February 29th, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
So it's Leap Day, so this episode will disappear next year, right? Is that the idea?
What will happen?
What you got on your tie now, Daniel?
This is my biohazard bow tie.
So those are little biohazard symbols?
Yeah, little biohazard, you know, the sort of weird thing there.
All right, good.
All right, let's jump into it. I try to keep these short, but then, stuff happens and we need to talk about it. So let's start off with our quotation because it's maybe a tribute to all our listeners. The highest activity a human being can attain is learning for understanding, because to understand is to be free. And that's by Baruch Spinoza. I think a lot of people come here because they want to understand. They want education. They don't just want a little TikTok or a little soundbite. They actually want that understanding. So hopefully we can keep providing it for everyone. And hopefully some of that understanding is going to keep everyone safe so that they can be coming back for more. So we'll start off with RSV, an update on RSV, and this is good news. It looks like things continue to drop with RSV, so really down from that high peak, and this is also what we're seeing in the local area. So good news on the RSV front. And this is interesting, right? And we'll maybe get a little more into this this impacts some of our recommendations, right? So we're getting near the end of when we're recommending that last trimester vaccination for pregnant individuals because, by the time the child is born, we might be past it. So, we get sort of a little bit of regional nuance, but really March is going to be where we sort of start wrapping that up. March also is where we're wrapping up a lot of the Beyfortus, that passive immunization. Now, RSV vaccinations, right, for older folks, that's actually something that has a durability. So, if you haven't got your RSV vaccine, think about getting it, but not quite as under the gun as you were in the past. The flu going in the right direction. Still fairly high though. Still seeing a fair number of cases of influenza, but across the board we are seeing that really starting to go in a positive direction from a judgment standpoint and a negative direction from a quantitative standpoint. So good stuff there. But again, it's regional, right? Right here in New York, where Vince and I are recording from, we're really getting down into the low levels. But still, we've got some hot spots. I don't know what they're doing out there in Ohio. Wyoming is going strong. New Mexico, Oklahoma, Arkansas, Texas and Louisiana. So,
you're good with your states, Daniel. I'm impressed.
I feel like when I was in school, we had to memorize. And I don't know if people know, but Vincent, I have visited every single state except for one.
Alaska?
Never been to Alabama. No, I used to work up in Alaska doing hospitalist work.
You've worked everywhere in the world.
That might be true.
I have been to most states, but not all of them. I think there are 5 or 6 I haven't been to.
All right. Well, you got to get on that. So
yeah, I will.
All right. Let's jump right into COVID.
Wait. Before you go, what countries have you been to? Rattle them off. I'm just curious.
I always forget, and I kind of run through these. So I try to do it kind of in a geographical spread. So we'll start Canada, United States, where I live at the moment, Mexico, going down to Panama, the Dominican Republic, a little bit into Haiti. I won't quite mention that because it's a porous border, so I'm not sure that was officially done. A lot of different areas in the Caribbean, Peru, and then moving over to Ireland, Iceland, England, Scotland, right? I'm going to separate you guys there. France, Germany, the Czech Republic, moving farther afield, Nepal, India, Thailand, Cambodia, Japan, a lot of visits to China, Zimbabwe, Zambia, Ghana, South Africa, Malawi. I'm forgetting stuff, but yeah, just sort of a smattering, lots of places.
I've never been to Australia?
I've never been to Australia.
Or New Zealand?
No, not yet.
And your South American visitation is just Peru, basically. Right?
I know. I need to spend more time down there.
All right. Thank you. I'm just curious because I know you travel a lot.
Yeah, and I'm sure I've left stuff out, so I apologize for the countries that I did. Okay. Oh, Spain! I go to Spain a lot. Sorry about that. So, and people probably who listen are like, "But Dr. Griffin, you didn't mention Bonaire. You didn't mention the Dutch Antilles." And I'm going to actually be in Denmark in April. So, sorry I left Denmark out. I've been there. Belgium. Yeah, I'm sure I left lots out. So,
not to Italy, huh? You haven't been to Italy. Last one.
Never been to Italy. Yeah.
Oh my God, you have to go to Italy.
Yes, that is on the list.
Okay.
Kenya. I forgot Kenya. Okay, so going into COVID, now that we've stopped my world travel update, a little bit of improvement. We are still, just want to say this, we are averaging over 200 deaths a day still. So, when we talk about different things like, okay, yeah, that might be better than 2,000 deaths a day that we were seeing in the U.S. in the early days, just in New York alone. But still, 1,569 deaths last week, average about 2,000 deaths a week from COVID. That's too many. But we are, as we talked about with RSV and influenza, we're seeing from a wastewater surveillance, things are going in the right direction in most of the country, and actually the country as an average. So moving in the right direction there.
So Daniel, flu, RSV, SARS-CoV-2, all trending downwards here at the end of February.
Yes. And actually, dare I say, as anticipated.
Yeah.
All right, so this was a bit of news. We'll spend some time on the COVID active vaccination section. And so I will start this section with the news that yesterday, we're recording this Thursday, so Wednesday, February 28th, 2024, the vaccine advisors to the Centers for Disease Control and Prevention recommended that people ages 65 and older receive an additional dose of the current monovalent COVID-19 vaccine this spring. And CDC Director Mandy Cohen endorsed the group's recommendation. And here's a quotation from Dr. Cohen. Today's recommendation allows older adults to receive an additional dose of this season's COVID-19 vaccine to provide added protection, said Mandy Cohen. Most COVID-19 deaths and hospitalizations last year were among people 65 years and older. An additional vaccine dose can provide added protection that may have decreased over time for those at highest risk. Now, I'm going to put in a link to the slides from this discussion as they give an insight into the science, but also its limitations, right? So I'm not sure that what Dr. Cohen said is, point by point right on. So I'll discuss what why I say that. So a couple things that they talked about. So the first thing is do people care? Are people 65 and older interested in COVID vaccines? So they have a slide where they actually, ask people what, concerns about COVID-19 disease, confidence in COVID-19 vaccine safety, confidence that COVID-19 vaccine is somewhat or very important to protect me. And when you look at people 65 years of age, we actually see that the majority of them feel confident in the vaccine safety, and the vast majority, like 78% of them, actually feel that the COVID-19 vaccine is an important thing to protect them.
However, Daniel,
yes,
the numbers of people they looked at is nothing. It's ridiculous. 65 people in one bar. I mean, this is no way a section of the U.S. Come on, that's CDC.
So yeah, we should look at more people. The other, and I think this is interesting, right? Because we're gonna talk a little bit about what do these extra doses do. But I want to point out that this is on top of really broad immunity across the population. And so if you look in the different age groups, and they have a slide where they talk about this, only 1 to 2% of everyone in the United States is I will say unprotected from an immune point of view. And so talking about this population, the 65 years and older, we are seeing that the majority, 58%, have hybrid immunity. We're seeing that there's some infection-only seroprevalence. There's some vaccination. About a quarter of 65 and older have what they refer to as vaccination-only seroprevalence. So the idea is actually a quarter of these folks have not had a COVID infection. That immunity is purely from vaccine. So, as we always talk about, the ACIP and these different groups are trying to give recommendations about public health issues, right? Where we often, when we're sitting face to face, we're talking about an individual. So they phrase their discussion in the context of what are the public health problems that they're trying to address. So as we talked about, COVID-19 hospitalization peaked in late December, early January. However, there still are approximately 20,000 new hospital admissions and 2,000 deaths each week due to COVID-19. And why are they targeting the greater than 65 years? These folks have the highest COVID-19 hospitalization rates. And, the age is really a big issue when it comes to hospitalization. Also, mortality, particularly the 75 years of age and older. So they looked at some data. So there is some science here that they're looking at. And one of the things they looked at is something we've been talking about is what is the durability of protection, right? We're not expecting these boosts to restore protection, restore high antibody levels for a year. We've talked about a 3 to 4 month expectation. And when they looked at the, and I'm going to focus here on the greater than 65 folks, you see the highest vaccine effectiveness, and this is against hospitalization, right? It's not infection, it's against hospitalization. You see the most significant in the first 2 months. You still see solid protection out to 120 days. So that's about 4 months. And once you get past there, you really start to see a drop in that calculated absolute vaccine efficacy against hospitalization. And we see a similar pattern when we also bring in hospitalization and critical illness.
And Daniel, can I ask, in the hospitalization VE, the younger people do worse in some of the 60 to 119 days and the 120 to 179 days. They do worse than the older people. Why is that?
Really interesting, because they have a whole section where they talk about immunosurveillance and why it's so important to get the old people these updated vaccines. If you look at the data, you're starting to say, and the young people need it even more often. Big error bars, I'll give you that. And clearly by the time you get out to 120 to 179, the young folks, right, the 18 to 64, that's like coming smack down at a vaccine effectiveness back down to 0, right?
And remember, as you said, this is the original monovalent and bivalent booster. It is not the current form or Omicron formulation.
Mm-hmm. Yep. So that's kind of, I think, part of the reality check, right? And they acknowledge the reality check. So people are looking at this and saying, oh, but if you get another booster, we might restore some degree of protection. Well, as they point out, no clinical trial immunogenicity data of this additional dose that they're talking about right now. But they do say, that initial dose does get a robust elicitation of neutralizing antibodies. And it is providing protection against JN1 and other circulating variants. So what are they going to recommend here? So here's what it comes down to. So the ACIP recommends that persons 65 years of age or older may receive an additional dose of 2023 to 2024. But we're going to talk about May in a second here. They say that this should be informed by clinical judgment of a healthcare provider, personal preference, circumstances, considering the additional dose based upon the person's risk for severe COVID-19, the additional dose administered at least 4 months after that previous dose. But then there's this whole big discussion about the word may. Should we really say may, which is just sort of like, yeah, you could do that? Or should it actually be a recommendation? Is this a should? Are they going to encourage people? Are they going to say, in our expert opinion, based upon, as they acknowledge, very weak evidence, limited amount of evidence, but what they do know, does the discussion change that the recommendation is ACP recommends that persons greater than 65 years of age should receive an additional dose? And they actually, an amendment gets introduced, they switch the voting measure to the stronger recommendation, and we end up with a final measure passed with 11 votes for yes, 1 vote no, 1 abstention.
So let me get this correct. So this is like an XBB version vaccine, basically, which was first launched in the fall. Is that correct?
Yeah, so they're saying, if you got that shot in the fall and you're
Right.
65 and older, this committee recommends, suggests that you should get an additional dose.
Okay, why don't we have clinical data from that first dose in the fall? You had plenty of time. You had the respiratory virus season. You could have done a great study. Why don't we have anything, CDC?
I think the biggest, I guess my biggest contention is, well, so again, this is quote unquote expert opinion, what they call the Delphi consensus, where you get a whole bunch of people in a room and say, we don't actually have data, but we're going to recommend you do this. And
Right.
then, I think because the big data is, will this additional dose give us that extra? Will it restore somehow this protection that we
I understand that, but they didn't even look for the first dose to see if it is
in this discussion, right? Where's the slide with the data on, because we've talked about some data on the current, but where was that in the slide deck? Yeah.
I mean, I don't want to be anti-vaccine, but I would like, I don't think if you make recommendations without scientific data supporting them, you're eroding confidence in vaccination. And that's not good.
Yeah, I think, interesting. And I spent a little time, but I actually, when you talk about this may versus should, I like the may, but again, maybe this has a legalistic implication. So if you look at it, you say, listen, you're over 65, you're interested in getting another vaccine. We think you're going to get a boost in antibodies for 3 to 4 months. It's been past 4 months. We've talked about individuals where they have a discussion with their provider and then they try to go get the vaccine and the insurance company say, oh, nope, you're not eligible. Our system doesn't allow that to happen. By giving a should recommendation, does it increase the access? I don't think we're going to get an onslaught. I think we're going to get a few percent of our population going for this extra dose. And, how much of this is sort of opening up the public health access to these additional doses versus how strong is this should? I mean, we probably need like a third word, this sort of a soft should versus a, thou shall.
How about must?
Must. That's a good one too. I don't think we like shall and must in America. So
No.
yeah, but I think this is going to be out there. People are going to be discussing it. And there are certain patients that this makes sense. We think, and again, just putting it in the couch. But yeah, this is always that challenge. We have to be careful when we make should vaccine recommendations, because after a while, it's the boy who cried wolf. They want to see the science. They want to see that this is really making a difference. So,
is there any negative of getting a booster in the spring?
Yes, I think that's the great thing. Is they talked a lot about is there a downside? Is there a risk? And the overwhelming realization, the discussion was that these are incredibly safe vaccines, right? I mean, they're biologically impactful, so it's not zero risk, but that risk is incredibly small compared to the potential upside to boosting those antibodies, maybe even some kind of a T cell boost for some period of time. So that's really what's risk benefit discussion. But if you're, let's say, 22 years old and you had a COVID infection like so many people did during January, I think it makes sense to focus on a higher risk group.
So one person voted no. Do we know who that is?
I wanted to find out who was the no and who was the abstention. So we may have to play back the tape to find out who that was. And then I thought about, well, I probably shouldn't find out and mention it. I'll look on my own time. And
No, I mean, it's always curious to know why someone voted a certain way,
Yeah.
right?
Well, what's really nice, and I should go back and sort of, just spend a little time looking at that, is that they give their reasoning. They say, this is why I abstained. This is why I said no. Everyone votes, and then they get their sort of, let me explain why I said that. And that can be really informative. And the other, I should say, at the same sort of context, in the slide deck was also this question that they asked, percentage who say they are taking each of the following precautions because of COVID-19 this fall and winter. So it's actually a survey that was done back in the fall. And, there's this perception that no one cares about COVID anymore. But actually, if you look through some of the responses, a significant percent of people are avoiding large gatherings. Some people are still wearing a mask in crowded places. Some people are making decisions to avoid travel. Some of us are still avoiding dining indoors at restaurants. There's still a percent of our population that are taking a COVID test before visiting with friends or family. And if you say, are you doing anything? A solid percent of folks, though they're not necessarily publicizing this, but they're making decisions to try to keep themselves and their loved ones a little bit safer. Now, this is I think this plays right into our discussion, is the brief report, U.S. state vaccine mandates did not influence COVID-19 vaccination rates, but reduced uptake of COVID-19 boosters and flu vaccines compared to bans on vaccine restrictions. I mean, that's like all right in the title, published in PNAS. So here the investigators use state-level data from the CDC to ask the question, they say to test whether vaccine mandates predicted changes in COVID-19 vaccine uptake, as well as related voluntary behaviors involving COVID-19 boosters and seasonal influenza vaccines. So they suggest that the results showed that COVID-19 vaccine adoption did not significantly change in the weeks before and after states implemented vaccine mandates, suggesting that mandates did not directly impact COVID-19 vaccination. So I was a little surprised by that. Interesting. Compared to states that banned vaccine restrictions, we've discussed a few of those, states with mandates had lower levels of COVID-19 booster adoption. So say that again. States with mandates had lower levels of COVID-19 booster adoption, as well as adult and child flu vaccination, especially when residents initially were less likely to vaccinate for COVID-19. So just a little closer look at the findings. So first, the investigators report. There was no statistically significant difference in weekly COVID-19 vaccination rates before and after the imposition of a mandate. They then go on to look at COVID-19 boosters and both adult and child flu vaccinations. And there's a number of different, I guess I'll say charts. You can look at COVID-19 booster proportions, and you've got, states where the COVID-19 vaccination rate, they've got it with standard deviations. I have to say, a lot of potential confounders here, but it does raise this issue about when you start mandating things versus sort of approaching vaccine decisions with an educational campaign. There's a potential risk of mandates having kind of this negative response from the public. I don't know if you had any thoughts on this, Vincent.
I mean, I think it's a backlash against mandates, but who's covered in these mandates? Is it just for school, or is it a broader population?
So as we saw in New York, different populations, so initially, right, it was healthcare workers, but we also saw schools, we saw different occupations. So yeah, really a lot of different situations where the vaccines were mandated.
I mean, I think mandating for school entry is a great idea, but I think as this study shows, maybe in a broader population, I mean, healthcare workers, the hospitals, the healthcare institutions should have their own flexibility, I think, right? But when you go to a broader population, I think there's a backlash.
Yeah. And I think, we worry, right? We're seeing issues with measles vaccination rates. We're seeing this sort of spill over into other areas. And so
in your place, Daniel, in your hospital, does your hospital mandate vaccination, or does it come from the state?
So early in the pandemic, that's interesting. It came from both, right? So you had it mandated, and then you had dare I say it, enforced by the different healthcare facilities. And then interesting, there was kind of this rebound after the fact where things got lifted, and then a lot of people who were let go because they had not gotten vaccinated were then, reemployed. So it's a very interesting dynamic going on there. And actually, I should mention this. I don't know if you've been following the meetings. They were Wednesday, February 28th, and then it'll be also the 29th today. There's meetings going on. But there was a plan to discuss novel OPV2 in the U.S. I don't know if you caught up on this. Dr. Sarah Kidd was going to be leading the discussion about the potential of using that here in the United States.
This is dead in the water. It is not happening. Okay. If they think they're going to reintroduce OPV in the U.S., they're out of their minds. They don't know biology. They don't know public health. They don't know history. This is not happening. This virus causes paralysis in kids. You think that's going to work in the U.S. when we have IPV, which doesn't cause paralysis. It prevents it. I don't see any logic in talking about this and even putting it on the agenda. What is the purpose? You know what it is, Daniel? IPV doesn't prevent transmission of poliovirus. And they're thinking, well, NOPV2 might for a short period of time. But the negatives far outweigh that. I think IPV should be used globally, frankly.
Yeah, so I do too. And and when people say, oh, but it's so expensive, come on, we're building aircraft carriers.
Yes, indeed.
Yeah. All right. So moving to COVID early viral phase, number one, right? NIH treatment guidelines, et cetera, IDSA, paxlovid. Another nice meta-analysis, effectiveness of nirmatrelvir, ritonavir on severe outcomes of COVID-19 in the era of vaccination and Omicron, an updated meta-analysis published in Journal of Medical Virology. I do want to point out there are lots and lots of studies now. So don't let someone just cherry pick one. And here they're going to look at 32 studies included in this meta-analysis, and they're going to do pooled risk ratios. Basically, we are seeing nirmatrelvir with a mortality pooled risk ratio 0.36, hospitalization 0.43. When you combine them together, 0.52, progression to severe disease 0.54, and then you see subgroup analysis on vaccinated patients as well. You're seeing a lower effectiveness on mortality in that group, but similar effectiveness when you look at hospitalization and/or mortality or progression to severe disease. So the authors comment, and I'll agree with this updated meta-analysis robustly confirms the protective effects of nirmatrelvir on severe COVID-19 outcomes. We're seeing, across the board, about a 50% reduction. So when people start talking about, oh, maybe they're charging too much and we should get the price down, yeah, that's great. But even in vaccinated patients, as we see here, even in the time of Omicron, we're seeing that this is really an effective tool that we should be using. Number two, remdesivir, as we've discussed, not getting quite as much use. And number three, molnupiravir. So what about molnupiravir? The article randomized control trial of molnupiravir, SARS-CoV-2 viral and antibody response in at-risk adult outpatients was published in Nature Communications. In this study, non-hospitalized participants within 5 days of SARS-CoV-2 symptoms were randomized to receive molnupiravir. We've got 253 or not, 324. They studied viral and antibody dynamics, the effect of molnupiravir on viral whole genome sequence from 1,437 viral genomes. I'll applaud not just PCRs. They actually collected swabs and viral transport medium and then cultured these on Calu-3 cells using a high-throughput culture method with screening over 7 days for evidence of cytopathic effect and the presence of SARS-CoV-2 bilateral flow immunochromatography and PCR. They were able to recover viable virus. Now, the positive culture rates for samples collected during the treatment 2 through 5 was 10.4% with molnupiravir versus 15.2% for the not getting. They say usual care, but I'm going to say like people that didn't get treatment. I hope that's not the usual care.
It's azithromycin, Daniel.
And steroids, don't forget.
Horse paste.
Oh my gosh. Post-treatment viability, days 6 through 20 dropped to 5.1% for molnupiravir and 2.5% for usual care. Now, they reported that molnupiravir was associated with lower anti-SARS-CoV-2 spike antibody titers. Serial sequencing revealed increased mutagenesis with molnupiravir treatment, dare I say, as expected. I think their conclusion is we should give more and more days of molnupiravir, but, yeah.
Isn't what we want to know the effect on progression to hospitalization, not positive cultures?
I agree. And we have good data that molnupiravir, though not as effective as paxlovid, not as effective as remdesivir, is an effective treatment, and it should be if you're not on one of the other two, the usual care. All right, convalescent plasma. Just so Arturo Casadebel remains my friend. I'll keep mentioning that. Isolation for the infected. We talked a little bit last week about rumors that the CDC might be coming out with updated guidance in, I think, April. So far the CDC has not said anything, but, a few states have actually started to change their guidance. So just echoing that the science has not changed, but some of the guidance has. And second week, the cytokine storm week. So remember, steroids at the right time, in the right patient, at the right dose, and for the right duration. And this is after the first week, and in patients with oxygen saturations less than 94%. We discussed a meta-analysis where they suggested that 6 days was adequate. Just will nod that the ID Society NIH treatment guidelines still have 10 days in there. Number 2, anticoagulation guidelines from a number of organizations, including American Society of Hematology, pulmonary support, remdesivir are still in the first 10 days, immune modulations in some cases, and yes, let's avoid those unnecessary antibiotics as listed by Vincent, even though it tastes like chocolate. If you like the taste of chocolate, go get yourself some dark chocolate. You don't need to have the paste. All right, COVID-19, the late phase past long COVID. And we have a fair number of things here. The article, Spontaneous Persistent T-Cell Dependent Interferon Gamma Release in Patients Who Progress to Long COVID, was published in Science Advances. And not only did I run across, but this was sent to me by one of my patients as well, a fellow sailor. But let us start with the study design. So unexposed donor samples, we've got 54, were recruited by the National Institute for Health Research, BioResource Cambridge, through the AREA, so the Antiviral Responses in Aging. It's kind of a cool acronym. This cohort was recruited before October 2019, so no participants were exposed to SARS-CoV-2 infections. The COVID-confirmed hospitalization patients, different group, right? And this is N of 51, day 28, N of 20 for day 90, N of 40 for day 180, were enrolled following admission to Addenbrooke's Hospital, Royal Papworth, and Cambridge and Peterborough Foundation Trust, with a confirmed diagnosis of COVID-19 via positive RT-qPCR. Then they enrolled long COVID study patients. We've got N of 55 there. Now, this cohort had symptoms that had persisted for at least 5 months after acute COVID-19 that could not be explained by an alternative diagnosis. As some patients were infected before routine testing began, a positive RT-PCR result, antibody seropositivity to nucleic capsid, or a positive IL-2 response to M and N peptides was required as proof of SARS-CoV-2 infection. The investigators detected persistently high levels of interferon gamma from peripheral blood mononuclear cells of patients with long COVID using what they refer to as a highly sensitive fluorospot assays. So these are not, I will comment, routinely available. But this interferon gamma release was seen in the absence of ex vivo peptide stimulation. So I'll explain what that means. Normally, let's say you wanted to ask if, has this patient been exposed to tuberculosis or something, and you're looking for memory cells. You would draw their blood, get those white cells. You're really focused on the memory T cells. You expose them to a peptide from the pathogen that triggers the interferon gamma release. Here, we're seeing that this interferon gamma release is occurring in these folks with long COVID, even without the peptide stimulation. And we see that the interferon gamma release was CD8 positive T cell mediated and dependent on antigen presentation by CD14 positive cells. Now, I mentioned a couple things. One is that this is not commercially available. You do see separation with some degree of overlap, but you're starting to see some separation here between the unexposed and the folks with long COVID. They followed the long COVID cohort for up to 31 months after this acute infection. And during follow-up period, I'm going to say this is what I found quite interesting, a considerable number of the patients experienced resolution of some, if not all, of their symptoms, either spontaneously or some folks are doing this after they get a SARS-CoV-2 vaccination. And they measured the unstimulated interferon gamma release in patients with long COVID before and after vaccination, and they found a significant decrease in the interferon gamma after vaccination that actually correlated with symptom resolution. So interesting correlation, but the investigators point out in their discussion that at this stage, it's not clear whether the interferon gamma is a mediator or a biomarker of long COVID. But yeah, interesting.
So as an immunologist, Daniel, what do you make of this?
Well, so normally when you turn on your immune system, right, to fight the pathogen, it's sort of a dangerous thing, right? You're unleashing the hordes, and now you've got to somehow get them to stop. Like, it's all over. Stop, being turned on, stop being activated. You want your CD8 positives, your killer T cells, your cytotoxic T cells. You want them to turn off. You expect that interferon gamma activation to settle down. And we're not seeing that. So from a mechanistic standpoint, it makes a certain amount of sense. And interesting that you vaccinate them, which we're hoping sort of helps steer the immune response in the right direction, maybe even clearing some remnant material that might be driving that stimulation. You see the T cells turn off like you're hoping, the people feel better. Mechanistically, this might make some degree of sense.
But do you think that there's antigen present, peptide, or is the T cells messed up in some way that they're just cranking it out?
I could buy either, and I don't know. I don't know which. Yeah.
All right.
Imagine I said, I don't know. Even though I went to medical school, I still remember how to say that. All right. The article, Blood-Brain Barrier Disruption and Sustained Systemic Inflammation in Individuals with Long COVID-Associated Cognitive Impairment, was published in Nature Neuroscience. So maybe we have a theme here, like this ongoing systemic inflammation that should be shutting down and doesn't. So here, participants included patients who had recovered from COVID-19, male or female, aged 18 and above, with or without neurological symptoms. Patients with long COVID with symptom persistence over 12 weeks from infection were also recruited. And here they're going to use this dynamic contrast-enhanced magnetic resonance imaging to assess blood-brain barrier disruption. And I think you guys may have even sort of discussed a little bit of this on the deep dive recent COVID. But they assessed this. They then did transcriptomic analysis of peripheral blood mononuclear cells to look for a dysregulation of the coagulation system and the adaptive immune response in individuals with brain fog. But sort of an interesting suggestion that there's some kind of ongoing systemic inflammation and maybe some ongoing blood barrier disruption. All right, more to come. The article, Prevalence of Persistent SARS-CoV-2 in a Large Community Surveillance Study, was recently published in Nature. And here the investigators identified 381 individuals with SARS-CoV-2 RNA detected by PCR at low CT values persisting for at least 30 days, of which 54 had viral RNA persisting for at least 60 days. In some individuals, they identified many viral amino acid substitutions. They say indicating, I'm going to change that to suggesting, periods of strong positive selection, whereas others had no consensus change in the sequence for prolonged periods consistent with weak selection. All PCR data, no viral culture, no plaque assays, no real ability to distinguish remnant RNA from replicating virus. What's exactly going on here? Does that persistent RNA drive any kind of ongoing immune activation? Vincent, any thoughts?
I heard Viviana Simon yesterday give a talk about her study at Mount Sinai where they followed a population of immunosuppressed patients, and they see long-term production of virus in that patient population. So I wonder in this one, how many of these are immunosuppressed? Because I do understand that immunosuppression, and it can happen in many forms, leads to inability to clear virus.
Mm-hmm.
So it reproduces and it sustains changes. It evolves in the patient over time. So this is only surprising that it's not in an immunocompromised population, or maybe they say it in the paper. I'm not sure.
Or maybe somehow you're identifying individuals who have some type, of immune issue, right? Like why is it persisting in them and not in other people? And again, we're sort of left with not really knowing if this is replicating virus or if this is just RNA that isn't being, cleared.
Well, in her study, they were able to culture virus from these individuals, right? They didn't quantify it, but they could do cell culture positivity. And many of them were treated with paxlovid, and 5 days was not sufficient.
Yeah.
So it could be that in this patient population, you need longer treatment, right?
Yeah, and in some immunosuppressed populations, it's a high RNA copy number. It's not these. Yeah.
So her study was done in New York at Mount Sinai, and they see spike changes arising before they appear in the general population.
Interesting. Yeah, and that's always been one of the concerns, right? That people are actually, producing these changes, sort of giving the virus a chance to improve fitness in the host, and then potentially,
right. Yeah. But what's interesting? So some of these amino acid changes lead to immune evasion to antibodies, right? But
yep.
These patients do not make antibodies to the virus.
But they're still, that's really interesting. Like that's fascinating.
Maybe it's just fitness, and that happens to be similar changes that cause immune evasion.
Yeah. I mean, that would be the only sort of, the evolution. What would drive that evolution? It has to be some fitness advantage to be. But it is interesting because we normally would say, oh, well, obviously it's immune evasive. It's being selected by the antibodies, but there's no antibodies there. So it's not. Yeah. Fascinating. So a small but encouraging study, long-term outcomes of hyperbaric oxygen therapy in post-COVID condition, longitudinal follow-up of a randomized controlled trial published in Scientific Reports. Now, context, back in July 2022, this group published the article Hyperbaric Oxygen Therapy Improves Neurocognitive Functions and Symptoms of Post-COVID, randomized controlled trial, also Scientific Reports, where they reported improvements in a number of symptoms with hyperbaric oxygen therapy, which they attributed to increased brain perfusion, neuroplasticity. So here the authors performed follow-up on that cohort. The protocol involved, are you ready for this? 40 daily sessions, 5 sessions per week in a 2-month period. The protocol involved breathing 100% oxygen by mask at 2 atmospheric, 2 ATA for 90 minutes with 5-minute air breaks every 20 minutes. Compression, decompression rates. 79 patients were randomized to either getting the hyperbaric or a sham in the original study. Out of the 40 patients allocated to the hyperbaric arm, 37 completed the intervention, performed the short-term evaluation. Of these, 6 declined their participation on any long-term evaluation. And accordingly, a total of 31 patients received the hyperbaric oxygen therapy, had both short-term and long-term post-treatment evaluations, and they're included in this current study analysis. A few limitations that, before we look at the data, as pointed out, the sample size ends up becoming relatively small with 31 patients in total. Second, the primary endpoint in the original study, cognitive function as well as brain imaging, were not evaluated in this current longitudinal evaluation. Since the original sham group, after completing the study protocol, were offered to be treated with hyperbaric oxygen, most of them received it, 69%. So they really couldn't serve as a proper control group. Now, they did, however, report that based on response to a short survey, there appeared to be encouraging long-term improvements in quality of life, quality of sleep, psychiatry, and pain symptoms. And they're using this SF-36, this short form 36 questionnaire. And I'll leave a link to it so you can kind of look at what they're asking. But if you actually look at the data, a statistician will tell you that this is interesting, but you're not really seeing any huge difference. And really, when you compare short-term, long-term, really looks about the same. And there's really no statistically significant difference between those two.
And is this hyperbaric therapy really practical on a big scale, Daniel?
I know patients are doing it. Patients are desperate. Yeah. Is it really practical? Are we going to have the hundreds of thousands, millions of people with long COVID end up in these hyperbaric oxygen chambers? It doesn't seem, and particularly when the impacts that we're seeing are as subtle as we're seeing on the SF-36. I'm not sure that this is really going to be a therapy for the masses, dare I say. All right, I will close it out there with no one is safe until everyone is safe. We're in our American Society of Tropical Medicine and Hygiene fundraiser, where for February, March, and April, we'll double your donations up to a maximum donation of $20,000. This is mainly going to go to scholarships for women from low middle-income countries to go to the annual meeting and hopefully allow them to make some connections and further their careers. So go to parasiteswithoutborders.com and click donate.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Theodore writes, I am a 46-year-old doctor taking biologics for plaque psoriasis and anti-IL-17 monoclonal. As I am considered immunocompromised, automated system for COVID-19 appointments allow me to do more than one shot per year. I've been doing 2 vaccines per year. My question is, do I really need more than one shot of the same vaccine each year? Does Cosentyx, which he's also taking, make me so immunocompromised to need more than one, or am I exaggerating? Colleagues that I've asked gave me a spectrum of answers from you don't really need it to be revaccinated if my antibody levels drop below 10 IUs.
All right. So this is a great question. And your timing is perfect. I don't know if Vincent, you sort of knew the timing on the ACIP meeting this week, but, this is in line with the current recommendations, as we've talked about, low level of certainty, not a lot of data to guide us here. So this is kind of an expert opinion approach. But the idea with the vaccines is you get this 3 to 4 month boost in, antibody levels, T cell, basically boost in our immunity, some boost in protection. We have that data we discussed where it looks like you start to wane and lose that protection when you get to about 120 days. So this idea about spacing them 4 to 6 months apart makes a certain amount of sense, but as we're talking about, we don't have tremendous data. And when someone gives you a cutoff, I'm going to say at this random antibody, I don't know where they make that stuff up, but we certainly don't have that degree of understanding that we can look at antibody levels and really pick who should and when get a next booster.
Jason writes, my wife is pregnant and just entering her 3rd trimester. It was my understanding that the recommendation was for pregnant people to get the RSV vaccine in their 3rd trimester. We asked my wife's OBGYN about getting the vaccine, and the doctor said they were no longer giving it to pregnant people now because it's beyond RSV season and no longer available. I looked on the CVS website, and CVS will still give the vaccine to pregnant people, so I know it's available. I could make an appointment for later today. Thus, I'm confused about being advised that it's no longer available. My question is whether the advice not to get the vaccine in the 3rd trimester is correct. Is there a downside to getting the vaccine? The only reason I could imagine not to get it is if immunity passed to the child was not expected to last until the next RSV season. Well, that goes against my understanding that the vaccine is fairly durable, though perhaps that is not true for the baby. I'd appreciate any clarification. If there is a benefit, we could go back to the OBGYN and push back on the issue. Obviously, if there is a benefit, I want to make sure the baby is protected.
Yeah, so this is great, and thanks for setting this in, and the timing is good too, because as we talked about, we're getting near the end. RSV is on the way down, but it's not gone, right? And so we're recording this on Leap Day. Is that what that's called? February 29th, but this will be dropping right as we get into the early days of March. We're getting right at the end, depending upon different regions. As far as by the time a person delivers, by the time the baby is born, will the RSV activity really be down? There's a downside, but you sort of getting into this timing issue. So you can think about when's your due date. Maybe you're going to deliver early. What if you deliver early and you deliver in mid-March? We still have some RSV activity. We're still doing Beyfortus in certain regions. There isn't a big downside as you bring up. I'm not sure you even need to go back to your doctor, right? I mean, this vaccine is going to be available because it's not just for folks in their last trimester. It's also one of the two options for adults. So it's going to be around. It's going to be an option. And so, I think that you've got to just sort of look at risk benefit. If you ran out this afternoon, and maybe that'll be Saturday afternoon when this has dropped, I still think you're kind of within that window. But yeah, you're getting pretty close to the end of when RSV won't be a concern this season. You bring up another, which is how long will those antibodies response? How long will that protection last? Well, we have our studies in adults showing a durability of the vaccine out to 2 years. But what we're talking about here is protection for the newborn, and will whatever amount of immune protection you transfer to that child, will that still be viable next winter? Probably not. So your child is probably going to be a candidate for Beyfortus, nirsevimab in the fall.
Michelle writes, my college-age son recently came down with mononucleosis while away at school. He's doing well after 2 weeks. My question is, how long is he contagious? I think I read that he could have virus in his saliva for up to 18 months. I'm currently on adalimumab, Humira, for IBD Crohn's disease. Since he graduates May 11, I obviously would like to go to his graduation and have him stay home with us for a week or so, but we wouldn't want to risk me catching the disease as I'm immunosuppressed. How easily can you catch mono, and how contagious would he be 3 months out? Can the virus travel in air? I don't know if I've had mono myself before, but I would think that by 61 years old, I should have been exposed at some point. Is there a test to see if I have some immunity?
Okay, these are great questions. So mono, in general, the most common cause of mono is infection with Epstein-Barr virus, but that's not the only cause of the mono syndrome, the clinical syndrome, like CMV. There's other triggers. So that would be the first question: is clarifying for yourself, is this an acute Epstein-Barr virus infection? If it is, we'll talk a little bit about that. If it is, it usually takes a few weeks from exposure to the onset of symptoms. By that time, a person is usually showing a positive IgM, a positive IgG. During the acute monosymptom phase, people tend to be contagious. You can actually, even during that period of time, you can pick up the EBV DNA in a blood test. They have a viremic phase. Unlike some other pathogens, I should say like West Nile virus, we really kind of got to look for antibodies because human beings do not get a tremendous amount of viremia unless they're immunocompromised. Now, when that acute symptom phase declines, and maybe they develop that mono, right? People who are feeling crummy for a couple months afterwards, that usually tends to move into a post-infectious sequelae. The serum EBV DNA will turn negative. The person is no longer contagious at that point. There are some individuals who are contagious for several weeks. There are rare individuals who remain contagious for months, who maintain an elevated EBV DNA in the serum, in the saliva. So a really easy thing to do here is clarify, is it EBV or not, or CMV, for instance, and do a serum viral DNA test. If it's negative, you're clear and can move forward.
Lewis writes, I'm traveling to Argentina in April for 2 months. I got the flu vaccine in August. Should I get a second flu shot as I'm going to the Southern Hemisphere as flu season begins there, or should I get a flu shot there? Is it the same flu shot?
Yeah, so It's the same flu shot, and you raise something that we have really good data on with influenza vaccination. Is you get the initial protection, let's say 2 to 3 weeks after the shot is really when it tends to peak, and then you lose. I'm going to throw this number, say about 10% per month. There was a recent study where it was 8%, so sort of a range there. But nowadays you got it, let's say August, so September, October, November, December, January, February. We're getting to the point where most of that protection, which does correlate in the case of influenza with antibody levels, where most of that protection has waned. So no, I think it's reasonable to get another flu shot. It makes sense. You just figure out whether it's cheaper or easier for you to get it here or down there. Still using the same, but we do know that when there's a meeting this spring coming up pretty soon, there's going to be recommendations for an update of the vaccines, and one of the influenza B will be removed. So we're going to be down to a trivalent because that one has gone extinct like the dinosaurs.
And Jeff writes, at the end of the last episode, with reference to the CDC guidance on 5 days of isolation following COVID infections, it sounded as if Daniel Griffin said, the science has not changed, the public guidance has. But it does not appear that the CDC has changed its recommendations on the website. And although I've heard a lot of speculation in the media, I have not heard any official announcements of a change. Can Dr. Griffin please clarify? As a clinician, I want to give patients the most up-to-date information I can. Recently, I've been saying that there's been discussion about changing the 5-day rule, but that nothing has changed on the official guidance. Is this accurate, or has the official guidance changed?
Yeah, so you're right on, and I'll just word that sentence. The official guidance from the CDC has not changed. And when the people that broke those stories reached out, the CDC said no comment. I can neither confirm nor deny. They plan to have an updated statement in April. It could be the same statement. It could be a different statement. So as mentioned, the guidance has changed. Certain places, certain states have said certain things. The science hasn't changed, and you are correct. This official CDC guidance has not changed.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone be safe.
No comment.